Hello, I'm Michael Savona from Vanderbilt University School of Medicine, Vanderbilt Ingram Cancer Center in Nashville, Tennessee. I'm going to talk today to you about how I take care of patients with MDS. I think it's important to recognize that MDS is myelodysplastic syndromes, a wide variety of different diseases encompassing marrow failure and a self-renewal defect, which can lead to acute leukemia. But MDS is sometimes a disease that people live with, and sometimes it's a disease that people die from. And that can change over the course of their disease. One of the most important things in the beginning is making sure I'm ruling out any other causes of cytopenias, because that can make it really difficult. You can have MDS and also have iron deficiency. You can have MDS and have copper deficiency. But it's hard to know how your treatment's working if you remain copper deficient, for example, during your treatment. The second thing is trying to get a sense of what kind of MDS you're dealing with. Is this the kind of MDS that your patients are going to live with and receive perhaps some erythropoietin stimulating agents? Or is it something that they're going to need a transplant to survive over the next year or two? And frankly, that's the breadth of different diseases that we have. Patients with low-risk MDS are often most plagued by decreased quality of life, fatigue, and sometimes transfusion dependence. Patients with high-risk MDS or patients who need disease-modifying agents in order to survive, and transplant is their only available potential curative option. We use a variety of different scoring systems, and the International Prognostic Scoring System has been improved to be the IPSS-R, and now the IPSS-M has just been released. What the International Prognostic Scoring System allows us to do is to look at the clinical phenotypic features of the disease, including which cytopenias, how bad the cytopenias are, if the patients have large structural defects in the genetics of disease, like monosomy 7, or if they have now with IPSS-M specific molecular aberrations, which we know connote increased risk. By going to MDS-risk-model.com, you can actually calculate IPSS-M fairly simply. Once we've established what the risk of the patient is, then it's a function of setting expectations and initiating treatment. Patients who have low-risk MDS are overwhelmingly patients with isolated anemia. I do have patients who have neutropenia or thrombocytopenia. But for the lower risk patients who don't have high risk mutations, who don't have a lot of blasts in their marrow, these patients can often do okay with agents that help stimulate erythropoiesis, namely erythropoietin stimulating agents, danazol or immunosuppression, and in some cases, luspatercept. Luspatercept and a host of TGF-beta ligand trap type medicines that are coming down the pike are late stage erythropoiesis stimulators and don't connote a risk of thrombosis as ESAs do when they're dosed to a normal hemoglobin. So it's careful that when we give people EPO, that we're dosing people up to 500 micrograms of darbepoetin a week at a max dose, or a weekly dose of 60,000 units of Procrit. Of course, we start off with lower doses than this, but it's important that we only dose these drugs when patients have hemoglobin around 10 or lower. If we do this, then these drugs are very safe with respect to clot. Historically, if you look back at thrombosis risk, this happened when people had hemoglobin's driven up into the 14 and 15 range. For patients with ring sideroblast, luspatercept is approved, and there's a current trial that we'll read out soon that tell us whether or not luspatercept yields benefit as it seemed to in the early phase 2 trial in patients who have low-risk disease who don't have ring sideroblast. Patients who have hypoplastic disease, meaning unlike most MDS where there's hypercellular marrow, there's a patient who's 80 years old but only has 10-20% cellularity in the marrow. Sometimes we want to use immunosuppression in those patients. I think one of the most important things is to understand which patients are at higher risk to developing AML. The IPSS helps that. Blast count in the marrow is helpful. Patients with EB1 and EB2 disease are likely to transform and do need disease-modifying agents. Typically, the standard backbone is DNA methyltransferase inhibitors, or HMAs, hypomethylating agents. And now, for patients who have increased blast, there's a growing sentiment that venetoclax can be used in these patients as well. The overall response rate with the different DNA methyltransferase inhibitors is about 60%. The complete remission rate across the board is about 20 or 30%. It's diminished in patients who have higher risk TP53 mutated disease and improved in patients who have a lower risk genetic panel. Regardless, patients who have higher risk disease should be considered for stem cell transplant. And now the age for allowable stem cell transplant is up into the middle and later 70s for patients who are fit. An early transplant referral, even when the diagnosis is first made, is important because transplant takes a while to find donors and prepare patients. So we do recommend an early referral to a transplant center. Now the availability of cord blood and haplo transplants make transplant available to most patients who are fit to have it. So that's one of the real unmet needs, is making sure we get more patients to stem cell transplant. We're able to receive it. Now that we have new agents to stimulate hematopoiesis or erythropoiesis, it's really important that we get a sense of just how many transfusions our patients are getting. In the transplant non-eligible population, or in low-risk patients who are not proper patients to transplant at the time, although they could progress, knowing how often we're transfusing patients gives us a good idea of what we have to gain. Transfusion dependence and quality of life surrounding transfusion dependence are some of the things that cause the greatest diminution of the patient's quality of life. It's an exciting time to take care of patients with MDS. We have a newly approved drug 2 years ago, a newly approved drug last year, and a couple of new drugs that may be approved in the next few years. So the outlook for our patients continues to improve. Thanks for listening.